Hello my dear champions, hope you are good and preparing well for your MRCOG Part 2 exam. Introducing myself, I am Dr. Dinesh, one of the mentor of Team StudyMEDICs. Now we are here to discuss about a very important RCOG module, and that module is SUBFERTILITY. SUBFERTILITY deals with the couple who are facing the problem in having the child and for the individuals who is facing the problem in terms of fertility for their futures. So let's discuss about the SUBFERTILITY module in detail, which is very important for your MRCOG Part 2 exam. As a ritual, let's have a beautiful quote for the session. The best way to predict the future is to create it. Whenever there are any hurdles in your path, you have to build up your new path with your own efforts, and we are just one of the catalysts to help you to boost your morals for this MRCOG Part 2 journey. So talking about SUBFERTILITY module, what are the very important things that you should be knowing about is about male factor infertility, female factor unexplained infertility, the mild endometriosis, how to deal with the cases, the indication of IUI, what are the indication of ICSI, and how many cycles of IVF can be given according to the age. So it is a part of a clinical governance for the RCOG modules. So let's talk about infertility in United Kingdom. 1 in 7 heterosexual couples do face this problem. The chunk of male infertility counts near about 27%. In female infertility, the ovulatory disorder counts for 23%, unexplained 23%, uterine and peritoneal factor of near about 9%, and tubal infertility is near about 18% cases. So 40% cases, both male and female can causes the infertility as a combined efforts. So, for the infertility assessment or clinical assessment, what are the investigations and whom we should ask for this investigation? A couple who is having unprotected sexual intercourse for 1 year duration and who are not getting conceived after 6 cycles of artificial insemination. Either it could be a partner sperm or it could be a donor sperm. These are the people to whom we will refer to the fertility specialist for the further evaluation purpose. In certain cases, the early referral will be considered. What are those cases? So early referral for a woman who's age 36 and above, because after this age definitely the fertility potential goes on deterioration. The woman with known clinical cause of infertility or predisposing factor for infertility. The planned treatment that may cause the infertility, for example, patient undergoing the oncological treatment and known to have the chronic viral infection like hepatitis B, hepatitis C, HIV, where there is a likely chances that with a natural conception, these patients may transmit the infection to the uninfected partner. So, considering the safety of the partner, this patient might require the fertility assistant for their further fertility dreams. So this is the one of the chart from your NICE guideline where it is mentioned about the cumulative probability of conceiving a clinical pregnancy by the number of menstrual cycle attempting to the conceive in different age group categories. So please be aware, after 1 year how many patients get conceived, and after 2 years how many patients get conceived. It would be a little difficult to memorize all the number, but understand as the age advances, the chances of getting conceived spontaneously after 1 year goes on deteriorating. That is the take-home message from this slide. Let's talk about the investigation of male infertility. We know that the WHO do come up with a newer criteria of semen analysis in 2021, that is the WHO 6th manual. But in NICE guideline, the older version of manual is still persistent. The WHO new manual is not yet been implemented into the guidelines. So for your upcoming MRCOG Part 2 exam 2024, definitely these are the mentioned parameters that you should be well aware, in which the volume is 1.5, the pH should be more than 7.2 or equal to 7.2, the sperm concentration should be more than 15 million and above, total sperm number is 39 million, total motility is 40%, progressive motility is 32%, and morphology that includes the normal forms of minimal 4%. If semen analysis is abnormal, then what should be done? Then repeat test to confirm the diagnosis. It can be done immediately if the gross spermatozoa deficiency has been noted, or after 3 months if there is a mild abnormalities into the semen factor. So this is the reason why WHO 6 manual has come up, just for your extra knowledge that yes, the medicine is an evolving science and we are into the era of evidence-based, and the current studies and the recommendations have proven that the certain criteria needs to be verified. So please go through this site whenever you get a time to understand that why we have come up with the 2021. Definitely whenever there is a revision of NICE guideline, these criteria will be implemented over there. Coming to the test of ovulation, the regular cycles are itself predicts that the patient is ovulating well. Women who needs to get investigated for infertility, even if there are regular cycles, then definitely that ovulation can be considered by means of mid-luteal serum progesterone, which is performed on day 21 in 28-day cycle. The longer or irregular cycle, in that context, check 1 week before the expected menstrual cycles and repeat it weekly until the next menstrual cycle. So when it should be ideally done, if it is a 35-day cycle, then definitely it will be a day 28. If 42-day cycle, then definitely it will be a day 35 that you will be considering for the serum progesterone level. So understand, in every cycle the luteal phase of 14 days is very constant. So definitely in 28 days it will be a day 21 where you will be measuring. In 35, then -7 it will be coming day 28. In 42, -7 it will be coming day 35. So what could be the value of serum progesterone? Sometimes you might get puzzled with it, but understand very clearly, serum progesterone at mid-luteal phase is at least 30 nanomole per liter, and the lowest threshold which can be considered as the ovulation been done is 15 nanomole per liter. Now for women with irregular cycles, there are the certain hormonal states that need to be confirmed, which include the FSH and LH. Understand, a very likely possibility of having the irregular cycle could be the excess ovarian reserve, that can be a possibility of PCOD, or diminished ovarian reserve, that could be a possibility of POI, that is premature ovarian insufficiency. And these are the two very important things that can come up in diagnosis by means of serum FSH and LH level. Yes, prolactin only if the ovulatory disorder along with there is a galactaria or any pituitary tumor, it can be considered. Talking about thyroid function test, if woman is having any symptoms which suggest that she could be a likely case of thyroid disorder, it should be performed. Talking about investigation for female infertility, in that context, if you see about the tubal testing, how to perform the tubal testing? Believe me, there are two modalities. One is the HHA and another is the laparoscopy. Somebody without comorbidities, definitely HSG will be the one of the cost-effective approach. But having the comorbidities like PID, pelvic surgery, previous ectopic, endometriosis, sexually transmitted diseases, and complicated appendicitis, in that context, it is far better to perform a laparoscopy, because it is not only about the patency, but these are the patients where the tubal adhesions or tube might be not fully mobile, so definitely it will hamper the fertility. Hysteroscopy should not be offered as a part of initial investigation. There was an era pre-IVF hysteroscopy used to be recommended, but right now in current recommendation it is not been considered. Talking about ovulatory disorder, as per the WHO, the ovulatory disorder are grouped into group 1, 2 and 3. The one is about hypothalamic pituitary failure, group 2 is about hypothalamo-pituitary ovarian dysfunction, and the group 3 about ovarian failure. So the one deals with the central nervous system, the 2 deals with your ovaries and the hypothalamo-pituitary axis, and the 3 deals with the target organ, that is the ovaries. So if it is group 1, near about 10% of the patient do land up in this category. In group 2, 85% patient, and more likely the patients with PCOS. And the group 3 include near about 5% patient, and understand 5% is the percentage limit that can be considered for a patient who are into the category of POI, that is premature ovarian insufficiency. Now the term of POI, that is premature ovarian failure, is no longer being used. So talking about the management of ovulatory disorder, understand, if it is a group 1 disorder where there is a hypothalamo-pituitary dysfunction is happening, it could be because of the increased BMI, it could be because of the excessive exercises, then yes, we need to perform certain tests and lifestyle modification. So for that patient, if the pituitary is not secreting good amount of the hormone, then pulsatile GnRH therapy or gonadotropins, which comes from the pituitary, that FSH and LH supposed to be given for the ovulation induction purpose. So this patient will have the low level of gonadotropin and low level of estradiol. So it will be considered as hypo as a case. Talking about group 2. Group 2, these are the patient having the higher BMI, so might be losing the weight, will be always helpful for them to get back their normal menstrual cycle. And in an order to get an ovulation induction done, For the pharmacological ways, we can consider clomiphene citrate, we can consider metformin, or we can consider the combination of this. So these are the patients who will be having the normal gonadotropin and normal estradiol level, and it could be one of the option where you can have the hyperprolactinic amenorrhea where the treatment is with dopamine agonist. Talking about this, hyperprolactinemia will be a WHO category 4. The group 3 includes a ovarian failure where the ovaries are not functioning. Definitely you will be lacking the oocytes, then getting the oocyte from outside, that is from donor oocyte, will be helpful over here. And this is giving the feedback to the pituitary by means of high level of gonadotropin and low level of estradiol will be the laboratory investigation that you can be coming up over here. A very important thing that you will be understanding in PCOS is that whenever your patient is on clomiphene citrate, there are two terminology called as clomiphene citrate resistant and clomiphene citrate failure. Resistant are the cases who fail to ovulate after 3 cycles. The failure are the cases in which clomiphene citrate has worked, they ovulated, but they failed to conceive. So understand these two terminologies very importantly. A patient is ovulating with clomiphene citrate, but they are not getting conceived. It doesn't needs any gonadotropin, laparoscopic ovarian drilling for the further conception and for the further ovulation induction. But yes, if your patient is on clomiphene citrate but they are not ovulating, in that context they will be labeled as a clomiphene citrate resistant. In that context, your patient will be requiring another agent which include the metformin, which include the gonadotropin, which include the laparoscopic ovarian drilling. Now, tubal assessment, as I already mentioned, in tubal assessment you need to consider the comorbidities and be very clear. The woman with no risk factor in their history should be offered tubal assessment after 3 cycles of the treatment of donor insemination or partner insemination, where you will be coming more closer to the diagnosis. So this is the investigation chart in which the pre-testicular, testicular and post-testicular causes along with the laboratory description for the male infertility patients has been mentioned. Pre-testicular causes are definitely the LH and FSH level on lower side, and the testicular testosterone level will be also on lower side, and in this context GnRH and exogenous gonadotropin will be considered. Testicular, where the testes are not functioning well, definitely this patient will be lacking the testosterone, but the gonadotropin will be on a higher side. So on that context, you can consider the sperm retrieval technique for like TESA, PESA, that will be helpful. Or if the test is not functioning well, there will be a lack of sperm, the donor sperm will be required. And in post-testicular causes, where the obstruction could be a pathology, so testes are functioning well, so hormonal profile will be normal over here. So the testicular post-testicular causes where the obstruction is there, remove the obstruction, and most likely the obstruction comes with the procedure done like a vasectomy, so reversal of vasectomy can be performed. Testosterone level undergo the diurnal variations, and they will be always in a higher amount when it has been performed into the morning. So let's talk about the management in a seropositive patient, specifically the HIV positive man. The HIV transmission risk is negligible if the man is compliant with the HAART treatment, that is highly active antiretroviral therapy, and the viral load of the copies is less than 50 for more than 6 months, and there is no infection present, and unprotected intercourse is only limited for the time of ovulation. If these criteria are met, then patient will be considered as low risk of having the transmission. If any of this is not present, then definitely for the purpose of even IUI, the sperm washing is required. If the patient is meeting with this criteria, definitely we are not requiring the sperm washing. Understand one thing, by means of sperm washing, we are reducing the risk of transmission, but we are not able to eliminate the risk of transmission. There are other infections like hepatitis B. In that context, the vaccinate the partner before you start your fertility treatment. Hepatitis C, then treatment to eradicate the hepatitis C before considering for the conception, because you understand that the severe consequences of hepatitis C is turning into a cirrhosis, and lastly into the chronic disorders. Talking about rubella testing, offer a vaccination for those who are susceptible to the getting infected with rubella, and there is no pregnancy for at least 1 month following the vaccination of rubella. Whenever it is a rubella vaccination, understand one thing, if patient getting conceived in that 1 month period, do we need to advise for the termination of pregnancy? No, because the congenital rubella syndrome has never been described into the literature for vaccine induced rubella, so it is not recommended. There is a very important viral infection that always comes into the exam, that is about Zika virus. So if the male is a traveler and the partner is currently pregnant, So if it is a scenario, then use the barrier method of contraception during the course of pregnancy, because these will prevent the risk of further transmission. And if currently the partner is not pregnant, then they should avoid the pregnancy for next 3 months after the last possible exposure to the Zika virus. If female is traveling to some other country and she is already pregnant, so then she should consider the further course of treatment depending upon the male partner has also traveled. If the male partner has also traveled, ask the male to use the barrier contraception during the course of pregnancy. But male has not traveled, but she has only one who traveled, then in that context she has to consider barrier method, and 2 months after the last, till the 2 months after the last exposure, that will be always considered over here. If female has traveled but she is not pregnant, in that context we need to think about male partner too. If male partner has also traveled, understand very clearly 3 months 3 months protection will be required. But male has not traveled, but understand which she should avoid the conception and use the barrier contraception for 2 months after the last exposure, so that will the eliminating the risk of transmission. So in that context, talking about baby is also very important, and considering the safety of the partner is also very, very important. Talking about unexplained infertility. Who are the patients of unexplained infertility in which all the fertility tests are perfectly normal and still they are not getting conceived? That will be labeled as unexplained infertility. Understand very important Bible line for this unexplained infertility. There is no any standardized treatment apart from just try for 2 years, and after 2 years if they fail to get conceived, definitely they are a candidate for IVF cycles under the NHS. So do not offer ovulation and induction with unexplained infertility because it does not increase the chances of pregnancy. Try for 2 years, 1 year of unprotected intercourse and 1 year in which where the investigations were performed as a part of evaluation kinetic. So we need to offer the IVF after 2 years for this patient because this is the need. There is a very beautiful talk article about unexplained infertility where they are talking about the IUI. That is one of the rationale in clinical practice, but as per guideline and recommendation for your MRCOG Part 2 exam, please understand that in unexplained infertility, no role of IUI. Talking about intrauterine insemination can be done intrauterine, intracervical too, unstimulated cycle and stimulated cycle also. So talking about unstimulated cycle IUI, these are the people who are unable to or would find it very difficult to have a vaginal intercourse because of clinically diagnosed physical disability or psychosexual problem, or who are using the partner or donor sperm, or after sperm washing, if there is a male who is already HIV positive, in that context you can perform, or people who are having the same sex relationship, in that context you can perform an IUI in an unstimulated way. But the success of stimulated IUI cycle is much better than the unstimulated IUI cycle. And if the patient is not conceived after the 6 cycles with partner or donor's sperm with a normal ovulation, with normal tubes and normal semen analysis, again you can ask for going for the 6 cycles of unstimulated IUI before turning into IVF. When we talk about intrauterine insemination, it can be considered for a patient of unexplained infertility, mild male factor and minimal endometriosis. But we routinely do not offer intrauterine insemination either with or without ovarian stimulation, and advise them to try to conceive for at least 2 years, and if they are not getting conceived, then yes, we do consider this patient for IVF. So these are the grave area where you might be into the dilemma, but understand if it is a mild male factor, mild endometriosis, IUI will be considered. But in unexplained infertility, IUI will never be considered as a treatment option. Talking about IVF is the last treatment modalities that any couple can desire if they are facing the problem of conception. So what are the criteria for IVF referral? If the patient is less than age of 40, the NHS offer the 3 cycles of IVF. So what is a 1 cycle of IVF? A 1 cycle of IVF in which the patient is been stimulated, the egg pickup is done, and the embryo has been created, and those embryo has been transferred inside the body. It could be a single transfer, double transfer, it could be a 1-time transfer, 2-time transfer, 3-time transfer, but that will be considered as 1 cycle. So this is the 1 cycle, 3 complete cycle will be provided for a couple who are less than 40. And it will be a funded cycle. Going ahead between the couple between 40 to 42 who has not taken a prior IVF treatment and there is no evidence of low reserve, and they will be always discuss about the additional implication of IVF and pregnancy at this age, because you understand very well that pregnancy in advanced ages put the risk for mother. So offer a 1 full cycle of IVF or with or without ICSI. ICSI will not be considered for all patients, but there are certain particular indications where ICSI will be considered. So what are the indication of ICSI? The indication of ICSI, before that, understand ICSI is the intracytoplasmic sperm injection in which one egg is been injected with the one spermatozoa, and that will be causing a fertilization. Normal IVF, what it has been done, one egg is poured with a 50,000 to 1 million of sperm, and so that sperm enter inside the eggs in a natural way. But in ICSI, it is an artificial way. We are having a micro manipulators, as we have seen in this diagram. So that will facilitate the entry of sperm inside the egg. So what are the indications? It could be a severe deficit of semen quality, obstructive azoospermia. In that context, the sperm will be retrieved by means of surgical modality, that is called as TASA, PASA, or also called as the surgical retrieval of sperm. Non-obstructive azoospermia, previous failed or poor fertilization in the IVF treatment. So what are the important things that you should be understanding? The very important thing that you should be knowing about genetic issues and counseling. Where the indication of ICSI is severe deficit of semen quality or non-obstructive azoospermia, the man karyotype should be established. A recent data suggests that the offering bonds to the infertile couple using ICSI have a higher incidence of chromosomal anomalies than the two children who are conceived naturally. But yes, the proportion is not that on the higher side. ICSI improves the fertilization rate because we are breaking the barrier of fertilization by directly injecting the sperm inside the eggs. So it improves the fertilization rate compared to the IVF alone. But once the fertilization is achieved, the pregnancy rate is no better than IVF. So at the end of the time, that is the very important crux of the story, that giving ICSI to everyone doesn't give any add-on benefit. Let's talk about embryo transfer. Whenever we are transferring an embryo in UK, no more than 2 embryos can be transferred as per the guidelines and recommendation. So when considering the number of fresh or frozen embryo transfer in IVF cycle, if patient is less than 37 years of age, in the first cycle, single embryo will be transferred. In second cycle, if it is a good quality, then 1 embryo will be transferred and 2 embryos will be transferred if it is not of good quality. In third cycle, definitely 2 embryos will be transferred because it will be giving a maximum chances, because 3 cycles are funded by NHS. For couple who was between 37 to 39, in first and second cycle, single embryo if it is of good quality and double embryo if it is not of good quality. And in third cycle, definitely 2 embryos will be transferred because it will be a last cycle. And in the patient 40 and 42 above, in the range between 40 and 42, double embryo transfer will be considered just in an order to get a better success rate. Let's talk about luteal phase support. Following the controlled ovarian stimulation after oocyte retrieval, there are multiple corpus lutea in the ovaries and which produce excessive steroids, which reduces the LH synthesis by negative feedback mechanism. And there is a deficiency in LH which can be minimized by direct replacement of progesterone or indirectly by correcting the LH deficiency by means of SCG or GnRH agonist, so that the pregnancy which has been there, it should be supported by means of hormone, because placenta will secrete progesterone which can help the pregnancy that happens there about 8 weeks after the pregnancy. So pregnancy test, it can be performed by means of urinary or blood beta HCG, which is to be done 2 weeks following the oocyte retrieval or after 2 weeks after the embryo transfer. And early pregnancy scans should be done at 7 weeks, so that you will come to know that where the pregnancy has been implanted so far. These are the indication of donor insemination, where you can consider the azoospermia cases, the severe male factor, whenever there is a risk of transmission by means of genetic conditions or there is a risk by means of viral infection. Again, confirm that the woman is ovulating and there is no history that suggests about the tubal damage. This is very important. Even in the severe RH isoimmunization, definitely donor insemination will be considered. Tubal assessment after 3 unsuccessful donor insemination cycles should be performed. Intrauterine insemination preferably rather than the intracervical, because intrauterine is the better success. And regularly ovulating women, at least 6 cycles of unstimulated IUI can be considered. But understand, stimulated cycle gives the better success. Talking about oocyte donation, whenever there is a no oocyte or oocyte offers no use, donation will be considered. So for example, it is a premature ovarian failure or premature ovarian insufficiency, as I mentioned, gonadal dysgenesis, or where the ovary has been removed by means of any chemotherapy, radiotherapy, or any gynec oncological condition. Certain cases where the IVF has already been failed, high risk of transmitting a genetic condition. So yes, in that context, the donor oocyte will be considered. The screening of donor will be done both for the infectious and the genetic diseases, and information regarding the potential risk of ovarian stimulation and oocyte collection should be discussed with the donor, and egg sharing scheme can be offered after counseling about its particular implication, because very soon the child will be well aware about the mothers after the completion of their 16 or 18 years of age. Endometriosis is a very important content. The guidelines is very vast, but in endometriosis, the things that you should be understand that how should be treated. It be treated by means of analgesics, hormones, and gonadotropin releasing hormone. It can be treated also with the aromatase inhibitor, specifically in a woman with endometriosis associated pain, which is refractory to the medical and surgical treatment, and it is recommended to prescribe the aromatase inhibitor as they decreases the endometriosis associated pain. And the last modality is surgical modalities. In order to prevent the recurrence of endometriosis, you can consider intrauterine system of LNG or combined hormonal contraceptive for at least period of 18 to 24 months. After surgical management of ovarian endometrioma in women not immediately seeking conception, clinical must recommend to offer a long-term hormonal treatment so that recurrence can be avoided. So these are some questions that I'll be flipping the side. Please go through the questions that will be very important for your MRCOG Part 2 exams. So these questions will be helpful for you to understand, and if there is any doubt with this question, please drop your query into the chat box. We will discuss about this question in detail. Very importantly, to wind up with this session, understand one thing. In terms of ovulation and induction, it has been very clear that how you should be approaching. Give clomiphene citrate, whether it is resistant, whether it is failure. If it is resistant, think about certain modalities like adding metformin if the cycles are not more than 6. Consider for gonadotropin. Consider for laparoscopic ovarian drilling. Laparoscopic ovarian drilling is a good option when your patient says that she is not ready to come for follow-up. Whenever you are giving a pharmacological agent, definitely your patient need to come for follow-up. When you are talking about resistant and failure cases, the resistance will be defined after 3 cycles of clomiphene citrate. I hope these sessions will be helpful for you. Please go with these questions, find out your answers and queries, and soon the college will be very proud to see the upcoming member of MRCOG degree holder. Wishing you lots of love and happiness. I'm Dr. Dinesh, one of the mentor of Team StudyMEDICS. Thank you.